Hello, everybody. I'm just waiting for Dr. Kaur to join the session. So just want to make her co-host as she is basically leading the session. I'll just help additionally. Okay. So I know she just finished teaching the class. So let's wait for a minute or so until she joins. If you have any questions from today's autonomic clinical case supplemental, I'm more than happy to answer until Dr. Kaur joins the session. Anybody has any questions on autonomic? While we are waiting for Dr. Kaur to join the session.
Dr. Shaw, I have a question about autonomics. For tomorrow's supplemental that you'll be doing for us for autonomics, will it be a case-based supplemental or will it be lecture-based supplemental or Q&A? What style are we doing tomorrow for
Tomorrow is pulmonary supplemental, regular.
I'll talk
From one,
okay.
you mean to say tomorrow 1 to 2, right?
No, I was under the interpretation after she spoke to us in class that we were going to have another autonomic one.
No.
But I could be wrong. It's okay.
Today, we have autonomic today from 4 to 5.
Oh, okay. Tonight then. Okay, yeah. For tonight.
Yeah, today.
What type of setup are we doing? Are we doing a case, multiple choice, Q&A, lecture style?
Well, I'll just open the floor for you guys to ask any questions, or we can just follow up on what we have discussed today in ANS clinical case, because that is more like a short of summary of the entire autonomic nervous system, right? So we can definitely review that case again, or I'm more than happy to answer any questions you have, during that time.
Thank you.
All right, so I think we have Dr. Kaur on board. I will make her co-host. Let me see, where is she?
Dr. Shah, I just have a
Yes.
quick question.
Yeah.
So would the ANS exam questions be kind of like what we're doing now? Well, you'll present a case and you'll say, here's are the symptoms and what is the mechanism of action behind some of these symptoms, just to give an idea of what to expect for myself?
Yes. One of the reasons why I discussed today with the case-based teaching or case-based learning, and I have analyzed the STEM in a stepwise fashion in a small pieces, so you can understand the underlying pathophysiological basis of all the clinical manifestations, and based on that you can determine the treatment and further line of medical management. Because if you know what receptors needs to be targeted with pharmacological drugs, then you can treat the patients. And to understand that, you have to understand what are the effect of this norepinephrine, or to some degree epinephrine, on this adrenergic receptor on different target organ, and how you can change that receptor by giving a drug. So in order to control the clinical manifestations or control the clinical patient symptoms, right? So that is the best way to learn physiology or pharmacology or clinical medicine. Otherwise, if you do not connect the underlying hardcore principles of physiology and pharmacology to diverse clinical scenario, you will feel that you are learning everything in the vacuum, right? It won't serve the purpose of teaching this subject until unless we bridge these principles to different clinical scenario, or to the application, clinical application of that. So it is very important, right? If for example, when we discuss about the case today in ANS, when we talk about norepinephrine in pheochromocytoma, which is released in excessive amount from that tumor cells, which is discharged directly into systemic circulation, and from there it will get to the different target organ, and one of the target organ is heart. Now, what would happen to the heart with the norepinephrine? Norepinephrine will activate the beta 1 receptor excessively in heart, and then what will happen to the heart when you excessively activate beta 1 receptor in the heart? It will increase the heart rate, it will increase the force of contraction, it will increase the conduction velocity, that all together will increase the stroke volume. And when you increase the stroke volume, you increase the cardiac output. And when you increase the cardiac output by Ohm's law, you will increase the blood pressure, right? So this is how, through the cardiac mechanism, the blood pressure is increased in a case of pheochromocytoma, right? So now we know that beta receptor mediated increase in blood pressure in case of pheochromocytoma. So you can design that drug that can antagonize or inhibit or block that receptor in the heart to suppress the symptoms of the heart in the patient. So you design a drug that can selectively block beta receptor in the heart, which will decrease the heart rate, decrease the force of contraction, decrease conduction velocity, that will decrease stroke volume, that will decrease cardiac output, that will decrease the blood pressure. But if we do not know pathophysiology of pheochromocytoma, then we cannot determine the line of treatment, medical management. How can you determine the pharmacological treatment without knowing what's happening at the receptor level in these patients? Does that make sense? Whosoever asks questions to me.
Yes, that does. Thank you, Dr. Shah.
Okay. All right. Let me see. Where are you, Dr. Kaur?
Yes, I'm here. I'm
No, I
here.
know you're there, but okay, now I see you. Okay. I just want to make you co-host.
I'm already co-host. I already shared the slides. So
All right. Oh, I didn't realize that. Okay.
Yeah.
All right.
Okay. All right. Let's get started. We have pretty much like an hour, a little extra for your questions later. But I want to finish more questions today. So I don't have the poll. So we're just going to go by the volunteer. Whosoever raise their hands first, and then we will go with the questions. Okay. I'm going to go straight to the question. Right. Here is question 1. And let me know when you're ready. We will continue week 3 tomorrow. Yes, Andrew, please go ahead.
Oh, thank you. Thank you so much. So the amount of air that he just took in, or as he, so he exhales as hard as he can. Oh, okay. So basically it would be the inspiratory capacity.
That's, I believe, wrong answer.
No, unfortunately, it's not.
Anyone else? Yes, Amir, go ahead.
Would it be vital capacity?
Very nice. It will be vital capacity. How did you get to that?
Well, I know vital capacity can either be one of two things. It could be either the maximum amount of air that you can exhale after maximum inhalation, or it could be vice versa. It could be the maximum amount of air that you can inhale after maximum amount of air that you can exhale after maximum inhalation. So it could be inhale. So basically it's the amount of air in your lungs that you can either breathe in or breathe out when you breathe in maximally or exhale maximally.
Beautiful. Very nice. Very nicely explained. Andrew, how is it different from inspiratory capacity now?
Was it vital?
It was vital.
Vital
He's asking me a
capacity.
question.
How do you think it's different from inspiratory capacity now? Did you get the point?
Oh, yes. Thank you. Yes. Okay. Oh.
All right. Please, whosoever is trying to talk like this, please don't disrupt the class. That's my humble request. We don't have enough time and we want to finish some questions. So, all right. Andrew, please continue what you were saying.
Oh, yes. So basically, vital capacity, we're going from maximum inhalation to maximum respiration. Inspiratory capacity, we go from our minor for basically the bottom of our tidal volume to maximum inspiration. So there's that whole reserve, functional reserve capacity, or not functional reserve capacity, that expiratory reserve that we're missing.
So just to explain to everyone, please keep in mind when you're looking at inspiratory capacity, you are basically including the tidal volume in there. But here in this stem, we have told you that they have exhaled as hard. So maximal expiration, and then they are trying to do maximal inspiration. So that will be the vital capacity or forced vital capacity for someone. So just keep, sharp eye on the stem that you get. Okay. All right. RV, FRC, TLC. What is common in these three? Yes, Michael, please go ahead.
Would those three volumes be the ones that can't be measured on spirometry?
Very nice. And what is FRC?
Functional residual capacity would be the residual volume plus the expiratory reserve volume.
Beautiful. And what is FRC as such, and how do you think it would change in different pathologies? Yes, Jasmine.
So, in regards to FRC, if we talk about emphysema, would be like losing the elastic recoil, so you have a lot of air in, and you have a hard time. With fibrosis, with emphysema, you have you have more air in your lungs, and so it's very hard to exhale. And so your in these patients, in order for them to be normal, your FRC would have to be increased for these patients in order for them to normalize. So like depending on if it's like emphysema or what that pathology is, you would have to change the FRC to match what their new normal would be compared to that of a normal person. Does that make sense?
You are close, but I was asking what is FRC? Yes, I mean, you explained it right for pathology. Yes, Andrew, please go ahead.
Well, sure, thank you. So is FRC just the amount of air that sits in your lungs basically after expiration?
Normal expiration,
yeah.
yes, after normal expiration. And this is the air that sits, and basically when your collapsing force on the lung and expanding force on the chest wall, they are in equilibrium, and those forces are equal and opposite. That's the air that you can accommodate in your lungs in the form of expiratory reserve volume as well as your residual volume, right? So the FRC, or functional residual capacity, is that amount of air which is going to sit in your lungs at any time after normal expiration, right? And it would change in different pathological conditions, as Jasmine just mentioned, the case for emphysema where compliance is lost and patient has lost their elastin fibers, so they can have more reserves sitting in their lungs, or they are trying to get at a new FRC or new normal where their lungs can still do their breathing mechanisms in order to get the air out or get in, right? The recoiling has to resume. So they are getting to another number or another volume of FRC, which will be higher than normal. And what will happen in case of fibrosis, for example? Yes, Jasmine.
So in cases of fibrosis, these patients, their elastin was replaced by collagen, so they have a hard time taking air in. And so if we're talking about chest wall versus their muscle, their new FRC would actually be lower than a normal person because they have a hard time getting air in. And so it would actually be lower for these patients.
Very nice. Let me explain it one more time. So basically, in case of fibrosis, the patient has scarred, thick lungs, which have more elastins now, and they would just snap back as soon as they try to inspire the air. So they can't keep that air inside the lungs, right? So their FRC is going to be now reduced as compared to normal because they are trying to get to a new normal where they can retain certain amount of air, and that would be lesser than a normal person, right? All right. So just be ready with all the pathologies and how they would impact the FRCs for the exam. So please make sure. And whatever I can finish today, please finish rest of the practice questions. The file will be up tonight. So for exam, it's going to be very important. Now, next question. Very important for the exam. Be ready with the alveolar gas equation. Let me know when you are ready and with your answer. Anyone? No volunteer for this question? Yes, Sina. Do you want to explain it? You're absolutely right.
Yeah, sure. I can give it a go.
Go ahead.
So since oxygen is 100%, I did 760 minus 47, and then times 1, so it's 713, and then minus 40 divided by 0.8. So
Beautiful. Very nice. I see Skylar's hand up.
Yes, I do have a question about this part. I'm a little confused why you would subtract by 47 since it says dry oxygen. Wouldn't that just be 160? Are you going to use
So my question is, are you from Middletown campus?
Yes.
Okay. So we have discussed this point a few times. Yes, yes, Melissa, for sure, I can do that. Let me go to the next slide. Yeah, here. So tell me, what is the atmospheric pressure out here at this level? Atmospheric pressure.
It's 760.
760, right? How did you get to this 160?
Oh, I'm sorry. It's my bad. I understand now. The 160 is the PO2, but then when it goes through like the nasal concha, it has to humidify, so that's 47.
Yeah. So whatever we tell you, remember I had told you, you better deal with this. You don't want me to give you any humidified air there. That's gonna be troublesome, right? So let's just plug in this 47 and we are good enough. So that's the water vapor pressure that you are adding with the moist lining that you have in the airways. And that's standard. So you just take out 47 out of that and you plug in your numbers. I'm sorry, the other question. I gave you already the answer for that one, but anyhow, the whole point is that you should understand how we do it. Okay, so Melissa, did you understand it or do you want me to explain it again? Melissa?
Oh, it's okay. Thank you. I think I understand.
Did you get the point or not?
Yes, thank you.
So here we are just talking about 100% O2, right? So we are plugging in 1. But if you had a normal atmospheric air, what did you plug in here, Melissa? What would you plug in here if you had normal atmospheric air?
21%.
Absolutely right. So, just keep that in mind. If you are given 100%, you're going to plug in 1, like whole 100% is oxygen, right? But if you were just talking about the atmospheric pressure or just the sea level, then you're going to plug in 21% here, right? And that's how you get to your point. And 47 is the humidifying or the moisture that portion that got in the airways. And then you have to subtract the CO2 that is being emitted at the lung level and then just plug in the respiratory quotient. That's standard 0.8 that you can use. Okay. Is everyone clear, Usman? What's your question? I see you are writing 150.
Oh, no, I was just saying that for 21%, you can just put 150. I mean, no
Yes.
760 or 40%, we'll put
Yeah, that would be your final answer if you are doing 21%, right?
yes, yeah.
Okay, perfect. I hope everyone got it, but it's going to be very important question for exam. This is going to be needed alveolar gas equation for your AA gradient as well. So you're going to see questions on AA gradient and alveolar gas equation. So just be ready. Be ready with that. All right, next question on your screen and tell me when you are ready. Any volunteer? Okay, Skylar, please go ahead.
Would it be 54?
Beautiful. And thank you that you are answering. I'm feeling very good about it.
Thank you.
That you got the point. Very nice. So basically, what did you do now? Your 760, instead of 760, I've given you atmospheric pressure of 542. So you're just gonna plug instead of 760, 542, but still out of 542, always remember 21% is gonna be your oxygen, right? So you plug in 0.21 there, and 47 is that humidification that you did when you took the air in, right? And rest of the numbers stay the same. Yes? As long as I haven't changed the numbers in the STEM for the exam, just go with the standards. But if if there is any change in the question, so just plug in those numbers accordingly. But I guess everyone got it now. So now my question for you guys, what is your dry inspired air O2 content at normal atmospheric pressure? I'm going to do it multiple times until you get it. 160, very nice, beautiful. 160 is your dry inspired air, right? Michael, do you get it? That would be the dry inspired air that we are talking about here. So let's see. This is the dry inspired air from the nose, what we are taking in, right? And then we try to humidify it. Yeah, we try to humidify it. And that's where you want to subtract the water vapor pressure, and this gets to 150. And how did you get 200 here? Why alveolar O2 is 100? Everyone, ready? What did you do here that this number is 100 now? Yes, Amir?
Oh, essentially what happens is that when that 150 milligrams of mercury in oxygen from your humidified air reaches your alveoli, now that's going to be diluted or that's displaced by the CO2 that's from your capillary blood.
Yes, beautiful. So, here is the venous blood coming, and that's where the exchange is happening. So carbon dioxide is diffusing out here, right? So that's diluting. So this 40 mm of carbon dioxide you have to take into account here, and your number gets down to 100 now. So whatever is here should be getting into the arterial blood. Yes, Diego, you have a question?
Sorry, maybe this was already explained. So we had 150 pressure PO2 on alveolar, and now we have 100 of PO2 and 40 of PCO2. Where did those 10 go? We're missing 10 units. I don't know if this is correlated or anything.
We are not missing 10 here, so you will have to plug this number into the alveolar gas equation. So if I go back this slide, remember here, so 40 divided by 0.8.
I see it now.
You got to put the respiratory quotient because you are utilizing how much oxygen consumption is there and how much carbon dioxide being produced. You are producing 200 ml per minute carbon dioxide and you are utilizing 250 ml of oxygen per minute. So you have to put this respiratory quotient here. Yes, Abraham, you have a question?
Well, me and a couple of our colleagues were a little confused with the equation. And I saw that it was 100% room air oxygen for number 2, but how come FiO02 is 0.21 and not 1 like the prior question? I'm a little confused on when do we plug in 0.21 or a different.
Because I gave you atmospheric pressure of 542 here, right? They are breathing this much. But the previous question told you that they are breathing in 100% dry oxygen, right? So you got to put like 100%, that's going to be entirely oxygen. That's your inspiratory oxygen. Make sense?
Yeah.
Does it make sense, Abraham?
In a way, I guess, can you flip to the next one so I can just see the P, A, and T maybe? So because, okay, it makes sense.
So Jillian has a question. Jillian, what's your question? So she's asking why would it be 160, not 150 for the dry inspired air? $160 is when we start to inspire, right? So this is 160 when you start to inspire. And this is when you take into account the humidification.
Oh, okay, I understand. Thank you.
Yeah. All right. Okay, let's get going. This is just the same thing what we discussed before, so I'm not gonna go, but be ready with the chart. It will be important for you and easy for you to go over the things. Jasmine, you have a question? Jasmine, you have a question? You are on mute.
Sorry about that. So I think where I'm getting confused is like for the first question where we plugged in FiO2 as 1 and the atmospheric pressure as 760. Why instead of why do we add 760 instead of 160?
So the water vapor pressure you have to deduce from the atmospheric, right? So you have to put the atmospheric because this is at the sea level we are talking. Okay.
Okay.
All right. Next question on your screen. Let me know when you're ready. Easy one. Yes, absolutely right. 1.5% and rest is all bound. So 98.5 is bound. That was not the point for bringing this question, and now the questions are coming to you. So how much is there in one gram of hemoglobin? How much oxygen is there in 1 gram of hemoglobin? Yes, Andrew. Go ahead.
Oh, would it be 1.34 milliliters of oxygen per gram of hemoglobin?
1.34 ml per 1 gram of hemoglobin. Very nice. So the homework tonight is get your hemoglobin numbers and try to see how much is your oxygen that is bound, right? So 1.34, let's assume your hemoglobin is 15. You're going to do that. So what if I tell you you are at 95% saturation, what would be your oxygen carrying capacity for hemoglobin? And how would you get to that number? So what I'm asking, 1.34 multiplied by 0.95. Very nice, Michael. Something is missing here. What's your hemoglobin number? Beautiful. Let's assume it's 15. Very nice. Very nice. Yes, Abdul, you have a question?
Do we have to know how to calculate the oxygen delivery, like when we include the cardiac output, or
Say it again.
like there's equation when we calculate the oxygen delivery, including the cardiac output? Do we need to know that?
No, you don't need to know that. If the question could be, it could be the oxygen carrying capacity of hemoglobin or the total O2 content. And that's where the soluble form that I gave you, that may come into account. So the soluble is, how much is soluble in blood per 100 ml?
1.5%.
No.
1.5%.
That's the percentage, right? So
Yeah.
in ml, how much is soluble per 100 ml?
1.5 milliliters.
0.003.
Very nice. Yes, 0.003 is at 1 mm of partial pressure of oxygen. So if I say 100 mm partial pressure, how much it will be? Love? You are there, Love. You gave me the answer 0.003 per 100.
Oh, 0.3.
Yeah.
0.3
point.
ml per 100 ml at partial pressure of 100 mm of O2. So just keep that in mind. If there is a question in the exam which is asking you total O2 content, that means you're going to do the solubility as well as the bound, right? If a question is asking you just the bound form, then you just go by 15 or whatever hemoglobin and how much saturation. That's how you're going to calculate. Okay? Is everyone clear? There are a lot of things going in chat. I'm not looking at that. So please tell me your question right here. So AU, who's AU? Amir, you have question?
Hi, yes, Dr. Kaur. So basically, from what I understand here is that if they're asking us for the O2 binding capacity for a bound oxygen bound to hemoglobin, then we use the hemoglobin amount multiplied by 1.34 milliliters maximum when hemoglobin is fully saturated. But if it's not bound, then we need to incorporate solubility of O2 multiplied by
Not
what was it, the
multiplied. So you're gonna do the bound form plus the soluble form. Go in the book. The book has very good examples there already done for soluble plus. So it gives you total O2 content. If I ask you just the bound, then you're gonna do hemoglobin multiplied by 1.34, and if there is any saturation levels that are given.
Oh, and okay, so then if it's for, if you're saying for total O2 content itself, that's when you have to include the
The
solubility of
soluble form
O2.
as well. Yes, Aisha, we are just taking an example, 15 gram. Aisha, that's just a number that we picked. Not necessarily. You can pick any number for yourself and just, try to apply it. Okay, there are some questions for CO2. Can someone ask me what question you are asking? Because there are a couple of follow-up questions, and I'm getting lost in there. So AU had a question. How does CO2 go from 0 to 40? Very good question, actually. Let me just go back and explain you. Who's AU, by the way? May I know the full name? No one is saying anything. Anyhow, here. So listen. See, if you remember, I had told you diffusion of any gas is heavily dependent on the solubility of the gas and how much pressure gradient is there. Is everyone clear about that? Yes. So for oxygen, we have 100 here, right? And 40 here. So you have huge gradient. So it's going to easily diffuse in, right? For carbon dioxide now, if you see essentially we didn't have anything in the alveolar air, which is very like marginal there, right? Fractional. So here in venous blood, you have 46, number 46, right? So this gives you a gradient 0 to 46. So it's going to diffuse out into the alveolar area. Does that make sense, AU? Did you get the point? I don't know where they are. They asked the question and okay. All right, so that's what we were talking about. How much a gas is soluble and how good is the pressure gradient? That is what is driving your gas diffusion, basically. Okay, that's what is driving the gas diffusion. Someone is trying to draw on the slides. Dr. Shah? Is Dr. Shah on call? I don't see him here. Okay, anyhow. All right, Priyanka, what's your question? Priyanka? That's the percentage. That's the percentage of oxygen which is soluble form. I hope you know it. That's standard. All right, I'm moving to next question. Everyone understands what's how we have carbon dioxide in blood, what are the different forms, right? The solubility 5%, and then you have fixed like 3%, something like that, and then rest 90 to 91% is basically in the modified form, which is bicarb. I explained in class as well today. So, after the aerobic metabolism, you produce carbon dioxide in the tissues, which is nicely diffusing into the blood and getting to RBCs. That's where your reaction will occur, and it's going to make bicarb for you, right? When it's making bicarb, it's also making a lot of hydrogen ions, which will be basically buffered by deoxyhemoglobin. So keep this in mind, like how this is being buffered. Now, bicarb, a very good question by one of the DO students earlier. I told you they were asking, how come if we are producing so much carbon dioxide, we only left with 46 mm in the venous blood? So just to tell this thing again, rest of the CO2 is all actually changed into bicarb, which is your major buffer in the blood, right? Which will be antiported with chloride and going to the blood. And when it comes to lung level, now this reversible reaction is going to take place and this is going to emit carbon dioxide. So this is going to go this direction and CO2 will be diffusing at the lungs level when this bicarb gets there. Okay, so that's how the things work. All right, I'm moving to the next question. Let me know when you're ready. Is the normal number. Normal respiratory rate is usually actually 12 to 20. The question states 8 to 14. All right, students are answering. Who's going to volunteer for this question? Can anyone explain it? Yes, Eliza?
So for asthma, you're not really getting as much air in.
So I just kind of thought of it very simply, but so less air with the alveoli, and you have difficulty breathing, so you're getting in less air. So I pick C.
Beautiful. Very nice. So the key point here is PCO2 is 60 ml, right? The normal is your 40. So just go by the stem. You got to look at the age of the person. So they are young, severe asthma, that is already told. Respiratory rate is very high. So what will be the minute ventilation in this scenario? Can anyone tell me? No, Priyanka, there won't be any normal values. You got to be ready with those. So minute ventilation is what is happening to minute ventilation here? Yes, Ame? Ame?
Sorry, Dr. Kaur. Sorry, Dr. Kaur. So minute ventilation would just be the amount of basically explaining how fast air is coming in and out of your lungs per minute. So it would just be respiratory rate times total volume, and that's basically actually increasing here because it's way above normal.
Very nice. Yeah, it's way above normal, and that is not the etiology of the CO2 retention, even though it is increased, right? So the increased minute ventilation is out. Decreased residual volume, do you think that's the case in this scenario? What will happen in obstructive disease? Is severe asthma. What will happen to the residual volume? Yes, Mark, very nice. So residual volume will be increasing because patients are having hard time getting the expiration done, right? And anatomic dead space, you cannot basically change it as such until or unless there is some kind of shunt there, or which can decrease the anatomic dead space, not basically increase, right? All right, so alveolar ventilation. If alveolar ventilation will be increased, how does that help CO2, which is 60 in this scenario? What kind of relationship it has? Yeah, it's gonna decrease it. So just keep in mind they have inverse relationship, right? What will be the treatment in this scenario? What do you give this patient? Beta-2 relaxant, very nice. Albuterol will bring. And what do you think is happening with FEV1, FVC ratio in this scenario? The ratio is decreased. Beautiful. We're gonna get there, so I'm not explaining that as such now. We're just doing questions and then I'll explain it later. All right, so minute ventilation is just your tidal volume multiplied by respiratory rate, whereas your alveolar ventilation will take into account the dead space, if there is any. We are talking about the functional dead space here and the anatomical dead space, right? You subtract that out of the tidal volume and then multiply with the respiratory rate. Okay. All right. Yeah, so there is anatomical dead space, which is basically 150 ml in tidal volume of near about 500, right? So this area, the air that is sitting here is never going to see the lungs, right? So no exchange for this air, basically. That's why we call it dead space. All right, next question. A relatively young guy, dry cough, decreased exercise tolerance for last few months, shortness of breath. PFT is giving you increased FEV1 FVC ratio. What do you think is happening with A gradient? Very nice. It's going to get increased. What does that mean? Can anyone explain us? What do you mean by A gradient increase? Any volunteer, what do you think? What do you mean by A gradient increase?
Dr. Kaur, maybe I can try.
Yes, Jasmine, please go.
I'm not sure if I'm totally correct, but A minus A gradient is the alveolar minus the arterial gradient. So if you have an increased gradient, there's a bigger difference between those. So in patients with fibrosis, they don't have that elasticity, so they have a hard time getting air in. And so having that lower alveolar versus the arterial, there's going to be a bigger difference between them. So that's why it's increased.
Beautiful. So let me explain it further. So basically, we're not going to talk about the membranes yet. Let's talk about just the gradient. The gradient means you have 100 oxygen partial pressure at the alveolar surface, and ideally, this 100 should get into the arterial blood, right? This is what is going to your tissues. But a patient who's having such a disease like fibrosis, as the patient seemed like having from the symptoms, they don't have the membranes as good, right? So they have thick scarred membranes where the diffusion is so difficult. The diffusion distance is such a big to travel. So diffusion is not going to be as good. So if they have 100 at the alveolar surface, they have probably 80 in the arterial area. So there is going to be, when you subtract arterial out of alveolar, you're going to see a bigger difference. Ideally, in a normal person, you won't see it. The difference is usually 5 to 7 mm, which is normal. And we had talked about physiological shunt earlier, where the bronchial blood and the coronary circulation blood is actually coming straight to the left ventricle, right? It's being poured directly into the left ventricle, and it's diluting the oxygenated number that's coming from the lungs, basically, right? So you see a physiological shunt or normal shunt of slight number change, which is normal for everyone. But in different diseases, different pathologies, if you see a gradient changing, that means whatever was sitting at the alveolar surface is somehow, because of different reasons, it may not go the same number into the arterial blood. So Alana has a question. In a clinical setting, you can't diagnose fibrosis with just spirometry testing. I mean, yeah, that's tricky, but at least the loops or the FVC number can tell you at least, okay, how the FVC is doing, right? If FVC is very low, that can definitely give us some kind of, suspicion there. And other thing is, you have to take a peek and see how old is the patient and what are the symptoms and when did it increase and what were the causes, any particulate things that we were talking earlier, like silica, asbestos, or any exposures for such organic stuff that they have had, which can cause or set up the fibrosis there. Yeah. All right. We're going to talk about it a little bit more as we move forward, but the PFTs, the overall loops, may give you slight, peek into those numbers. So the laws of diffusion, I'm going to talk about Fick's law of diffusion. So let's go straight to the lung diffusing capacity. How do you think that it will be altered in fibrosis, for example? And that's where you can detect something is wrong there. Anyone? Yes, Jasmine, go ahead.
So in fibrosis, the denominator, the change in X would increase because you have a thicker membrane than normal. So that would cause your V to decrease due to that inverse proportionality.
Beautiful. So V is your diffusion of the gas, right? Which is heavily depending upon the diffusion coefficient, surface area, and partial pressure gradient of the gas, right? What do you have outside and what you want to bring in? And heavily based on the denominator here, which is delta X, that's the thickness. Or if this membrane, the alveolar membrane, is thick or diseased or having any pathology which is not letting the diffusion take place that good, and that's going to impact the diffusion. So A gradient can give you a good, peek into that. So answering your question from before, yeah, maybe the PFTs won't be the final things, but DLCO and your A gradient numbers could be very well defined, the case there. Okay, is everyone clear about that? We good? Okay, so tell me, how is your DLCO getting impacted by emphysema? Which factors? You have factors sitting right in front of you, right? Yes, Andrew.
So the volume will decrease for emphysema. Would it be because emphysema we're losing surface area on basically for gas to transport?
Very nice. So basically, this is the A that we are looking here. That will be impacted heavily, and that will decrease the DLCO in emphysema. How do you lose surface area, basically? Yes, Usman, fibrosis will have a low lung diffusing capacity. How do you lose surface area in emphysema? Yes, Abram.
I'm not sure if I'm gonna remember this correctly. Is it because I think you spoke about it in class, because the alveolars are destroyed, they kind of like mold into one, or stick into one. Was it this
Yeah,
disorder?
yeah.
That's why
Yeah.
their surface area is destroyed in a way.
Very nice. Yes, the
Lump.
smoking is killing the alveolar walls. And what is the smoke? This is tar, all the nicotine, formaldehyde, all that stuff, which is basically inflammatory and causing the damage to the alveolar walls. So they are basically breaking now. And 2 or 3 alveoli, if you look at the smaller alveoli, you have more surface area to do the gas exchange. But as the walls are opening up, they are very inflamed. It's just gonna open up and become one large alveolus, which will be decreasing the surface area heavily to do the gas exchange. And moreover, basically, as I told you before, up above the alveolus, the capillary network, the whole bed is somehow lost because of the damage from the smoke that is coming there, because walls are becoming very thin as the compliance is increasing in emphysema. Okay. All right. How do you impact DLCO in exercise? Is it increased or decreased? Increased, right? Because you have more perfusion that is happening there, right? Your pressure gradient would be changing and your diffusion is getting impacted, right? All right, very nice. What about pulmonary edema? What's the factor for DLCO reduction? It's decreasing, but why? Pulmonary edema. It's not higher thickness. It's basically, since fluid is sitting there, it's gonna have a larger distance to travel, right? So diffusion is gonna be tough. All right, next question. All right. In case of emphysema, the gas diffusion curve is oxygen gas diffusion curve is changing to. Antonio just mentioned B. Very nice. Antonio, do you want to explain it? B is the right answer here. Antonio? Anybody else who would like to explain? No, Antonio, it doesn't have anything to do with the carbon monoxide binding. We are just saying that it will be a diffusion limited curve changing from perfusion limited, right? What kind of curve oxygen follows? Anyone? Yes, Sadaf, please.
So it will be B because carbon monoxide has the highest diffusion rate than oxygen and CO2 because it has a high lipid solubility, so it can cross the membrane much easier.
So let me explain it. I think yeah. So you got to see the difference between the two curves first. Just keep in mind the carbon monoxide has a diffusion limited curve as opposed to oxygen, carbon dioxide, or the nitrous oxide. They are all of them, they are under the category of perfusion limited here, right? Now, what do you mean by perfusion limited or diffusion limited? This means that the gas diffusion was not enough. It didn't happen properly throughout the length of the capillary. And here, the perfusion was not enough, otherwise more gas would have diffused. If there was more perfusion from this capillary or your flow of blood was even faster, you could perfuse more of this gas. Now, since oxygen follows perfusion limited, that means that oxygen gets into the capillaries from this green line is your alveolar surface O2, that is 100, right? So it easily gets into the blood and it gets into complete equilibration by 1/3 of the capillary already. If you had more perfusion, and that's why we say if you exercise and you bring more blood flow, you can bring in more oxygen. That's how you improve your DLCO, right? But here, why we say in case of emphysema, it's now changing from perfusion limited to a curve that is followed by carbon monoxide, which is diffusion limited, because the diffusion of O2 is not happening that nicely in there. Now, what were the different reasons? And I see in the chat, I see Diego has written hypoxic vasoconstriction. That is one reason. What else comes to your mind? So hypoxic vasoconstriction would be a perfusion limited stuff. But we are saying that O2 is changing from perfusion limited to diffusion limited, and that's the biggest reason in case of emphysema. What would be that? Perfusion is related to flow. Yes, Andrew. Very nice. Usman will go to carbon monoxide later, okay? Anyone who can tell me why do you think the perfusion limited oxygen curve is changing to? Yes, Diego, go ahead.
I'm not sure if I'm right, but is it because of the increased compliance, reducing the pressure within the alveolar? So reduction of pressure, reduction of DL?
Not really. We just discussed it. Yes, Amir?
Hi, Dr. Kaur. I'm sorry. It's I just have I'm mildly confused, mildly with what this is. I'm sorry, I didn't answer the question, but what I'm thinking of is, if I can just clarify, diffusion limit is essentially when a gas, if something's affecting any of the factors of the Fick's law, specifically membrane thickness or something involving the membrane, then that means that the gas is limited by its own diffusion process. Is that correct?
Absolutely right.
Oh, okay, perfect. So in that case, for perfusion limited, it just means that it doesn't really rely so much on, it's more likely limited by its ability to travel through the blood. And since nitrogen is only in the dissolved form, it has to rely on the blood to go from one place to another.
You're going into a different direction, Amir. Please stop your thoughts. We're talking about oxygen perfusing through the capillary. How come if perfusion is limited here, we're just saying that the oxygen follows a perfusion limited curve, right? Now this curve is changing to a diffusion limited curve. That is because in case of emphysema, you are losing the surface area. Simple. Simple.
Oh,
We just discussed it. Yeah. So
okay.
there is nothing to talk about the nitrous oxide here. It's just I was giving the examples of these three gases that they follow the same curve. They follow the same curve, perfusion limited. But now the curve that is followed by carbon monoxide, which is diffusion limited, someone who's having emphysema, they're losing the surface area, so their diffusion will be limited for oxygen just because of that reason. Does that make sense?
Yes, it makes more sense. So I think I get you right. I kind of went off on a little tangent with the nitrogen, but basically, I know you see what you're saying. If if a condition affects the status of the membrane, whether it be emphysema, COPD, or fibrosis, then it's going to become diffusion limited, and that would cause the perfusion limited normally for O2 to become diffusion limited.
Yes, absolutely correct. So in case of fibrosis, the reason of becoming diffusion limited is?
If you have like COPD, fibrosis, maybe you're exercising also. I think
I'm asking the reason in fibrosis. Yeah, the thickness increase. Very nice. Fatima just answered. Yeah.
Yeah. Sorry. Thank you.
All right.
Appreciate that.
Okay. Thank you. Sadaf, you have a question?
No, I was just going to explain the process, the question that you asked. That's all.
It's okay. It's okay. We all are learning, so don't worry. I mean, you still have 3 days. 3
Yeah,
days.
but one point that I think Amir did not mention, and I was not mentioned in the chat, is that so in case of fibrosis, the equilibrium is never reached. So people that have fibrosis can never reach equilibrium because the thickness is so much that the oxygen cannot reach the blood and the CO2 from blood cannot reach. And by equilibrium, we mean that the amount of oxygen has to be 100 in the blood and the amount of CO2 needs to be 47 in the lungs.
So amount of 100 that is sitting at the alveolar surface has to get into the arterial blood as well. That's what I meant. So it has to be 100 up here and 100 in the capillary as well.
Exactly. And for 47 of CO2, it has to be the same. So that's what we mean by equilibrium.
Yes. Yeah. Yeah. So this is a very good curve actually that you can follow, and that can tell you why diffusion is impaired in case of fibrosis, that they have thickened membrane. They never reach that point of 100, the equilibrium position, right? So they have some difference that is left. This is your A gradient difference. Does that make sense to everyone? You're welcome, Carlos. So is everyone clear about this A gradient here that we're talking? So you are not at 100. They can only reach up to, yeah, Amanda, thank you. So here you are left with certain difference, and that is your A gradient. Is everyone clear? Can I move forward? Yes? Anyone has a question? All right. Okay. All right. My next question to you is, why do you think there is a difference between inspiration curve and expiration curve? Yes, Andrew, go ahead.
Oh, thank you. Oh, is it down to a difference in compliance between the two curves?
Yes. Yeah, the hysteresis. Why? Yes, Sadaf, go ahead.
So hysteresis basically means, so okay, I'll try my best to like explain it the way that I understood. So in small alveoli, we have surfactants because surface tension is really high. So we need the surfactants to decrease this surface tension. So this competition between like surfactants and surface tension causes different types of slopes, and these different types of slopes are representing hysteresis.
Yeah, but why? Just why beginning of this slope is like that? It takes some time to kick, right? Why this kink is this? Yes, Diego.
Is because as the alveoli expands, the surfactant is dispersed throughout it, which helps increase compliance as it goes. So it makes it easier and easier to expand.
Yes. Yeah. Yes, let me add to that. So basically, just keep in mind the inside of the alveolar surface is moist. So there are strong, these liquid molecular bonds that are there and which have to be overcome. That surface tension has to be overcome by adding the surfactant. So initially, when you are trying to inflate the lung in the beginning of the inspiration curve, it's flattened here, right? Because it takes some time to apply that surfactant inside to overcome that surface tension, and the flattening, once it's all done, then it will just be smoother, right? And same thing when it tries to expire air out now, the compliance is very high. You have a lot of surfactant inside. So even though the air is going out, the lung is still compliant and having a lot of surfactant in there, which needs to be removed from inside, right? So it will slowly deflate. So you will see this flattening of the curve up here, and then slowly it would just start to go down, right? So that's the difference between the inspiration curve and expiration curve. So you just keep that in mind. Yeah. Okay. Clarissa has a question, Dr. Shah. I thought there was a question. Can emphysema be both? Yes, absolutely, Clarissa. So if you're talking about the loss of capillary network, the beds from the alveolar surface, that is taking away the perfusion. But majority of it is the diffusion limited is coming from the loss of surface area, basically, in case of emphysema, because the alveoli, they are becoming larger and broken and merging. Right. All right. Next question. Yes, Sadaf.
So the answer should be COPD.
Beautiful. Very nice.
And the
Would
reason
you
is
like to explain us?
yeah, sure. So the reason is because people with asthma, they have a low ratio of FEV1, FVC, because the air cannot, the 80% of the air cannot exit in the first second of expiration. So when we give them the albuterol or any medication that helps them with that, their ratio of FEV1 and FVC gets better. But people with COPD do not have that in there. So their FEV1 FVC ratio does not change. It will stay the same as it was.
Yes, because the name is basically, as name is telling you, it's chronic, right? Chronic obstructive pulmonary disease. So just obstruction at the airways is not the only cause. There are a couple of other pathologies that have set in by now, right? So that won't improve the FEV1 FVC ratio by just giving beta 2 relaxant. which is happening in case of asthma because problem is only at the airways, right? So you relax them and the patient is able to go back to their normal breathing, right? But here it's mixture of certain things that have happened over time. It could be inflammation set in, it could be problem at the alveolar surface area, it could be the problems at the obstruction, the secretions, and other couple of other things, the infections that are there, right? So you will have to add in more treatment to it. So what do you think the treatment should be for COPD? Yes, Abraham. Antonio?
Oh, yeah, I'll wait after Antonio. I have a question.
Oh, did you want me to answer what the treatment would be, Dr. Kaur? So, since the patient has COPD and they just got administered albuterol and albuterol didn't fully work and FEV1 is still where it is, you would add thiotropium to albuterol, which would actually help COPD patients, usually patients with chronic COPD, or administer tiotropium with albuterol to actually improve their condition. And then
So albuterol is a beta-2 relaxant. What does tiotropium do? What's the
thiotropium,
mechanism? What's the mechanism of action?
it's a bronchodilator.
Yes, but how does it work? Sada, do you want to take it?
Yeah, so okay. So for asthma, we give beta-2 agonist, but for COPD, we give beta-1 antagonist. We give beta blocker.
He just mentioned tiotropium, right? Do you want to give the mechanism to that?
Well, the mechanism is that it will decrease the beta-1 receptors, I believe.
No, don't go to beta-1. We don't need beta-1 here. We are talking about smooth muscle cells in airways, right? So yes, Mark, would you like to explain?
Sure, so I could try. So basically, I believe it's a muscarinic antagonist. So it's going to be on the smooth muscles. Excuse me. So if it's blocking the muscarine receptor, it'll block acetylcholine, which would cause the muscles to contract. So by stopping it to contract, it would automatically dilate. So it almost acts like a bronchodilator.
Beautiful. So basically, you are dilating by giving muscarinic antagonists in order to not letting those smooth muscles contract, right? And other thing is you are killing two birds with one stone. You are also calming down the secretions, right? Remember Dr. Fisher's videos from before? So just keep an eye on that. The secretions have to be snubbed as well in this scenario if it's a COPD, like, chronic case. And other thing, what would you like to add? One more thing to bring the inflammation down. I'm just saying it may not be part of your drug list. Steroids, very nice. So steroids to bring the inflammation down, right? All right. I hope everyone understands now. These will be the regular drugs that will be covered for ANS Pharm, and here in Palm. So yes, inhalers. Singular is not. Singular is for cytokines, I believe. Advair, I'm not sure. Dr. Shah, do you know? What is Advair for? I have no idea, Alana. Just go by the drugs that we have given you.
Hello, I'm sorry. I'm with pharmacology review. Hold on.
Okay.
1 second.
I
I'm
know
sorry.
that
What was the question?
Advair. What's the drug Advair?
The Advair is a brand name that has two components, two different drugs. One is fluticasone, that's steroids. Another is salmeterol, that is beta-2 agonist or activator. So
Okay,
beta-2
so she's correct.
salmeterol is a long-acting beta-2 agonist, and the fluticasone is inhaled glucocorticoids, and they both are there in the Advair, and they both are being used as inhalation to Advair. And what was the other drug?
Yeah, Singular.
Singular is basically Montelukast antagonist, which is used as a prophylaxis to treat mild or moderate bronchial asthma. It is used mainly in the children, because we don't want to give steroids in the children because they have a long-term, very detrimental effect on the kids. So we only use that. I mean, we mainly use in kids, but it can be used as a prophylaxis for all kind of asthma in any age.
Yeah.
It's a Montelukast antagonist.
Yeah, I thought the Monteclast is for cytokines, no?
The Montelukast is one of the mediator of inflammation.
Yeah,
That is
it's
released from the
for
arachidonic
cytokine.
acid.
Yeah.
Lipid. It's a lipid mediator.
Yeah, but Alana, the other one is correct. That's the beta 2 agonist. You're correct.
Yeah, that's a long-acting beta 2 agonist, especially.
Yeah. Okay.
Thank you. It was more because I know the albuterol is more a rescue, and then the others is preventative. So I wasn't sure if they both worked in the same receptors. But thank you.
Thank you. All right. So
And
let's talk
you
about.
guys don't have to know by the brand name. So
Yeah.
for MS students especially, don't worry about all these brand name, and we don't test we don't test any concept in this exam by the brand name. Okay.
Yeah. Okay. All right. So let's talk about the FEV1 FVC ratios. Can anyone explain us obstruction versus restrictive disease problems? Why you think that the FEV1 FVC ratio is increased in restriction or not changed? Yes, Diego.
On restrictive diseases, the ratio goes up because they have never had issues with exhalation. Their issue is with inhalation. So the natural elasticity of the lungs. First of all, the FVC goes down, and second of all, the exhalation is much more potent. So the ratio goes up. For obstructive, you have the opposite. There's too much compliance, so they are actually pretty bad at exhaling. They have no problem with inhalation, and on top of that, their FVC goes up because they retain oxygen, they retain gas. So that's why the ratio, the ratio is decreased.
Very nice. Thank you. So here, as you can see, and you can appreciate the numbers here, look at this FVC. This is almost 5 liters here, right? Christian, you have a question?
Yeah, so for like an restrictive disease, we're saying that the FEV1 and the FVC ratios increase, but it's still below that 80%, correct?
No, it's in restrictive disease, it can be 80%. It may look just normal, or it may just go a little extra, maybe 80 to 90%, 90%, somewhere there.
Okay.
It never goes down. I'll explain it in a minute. Okay. So here, if you look at this normal FVC, this is forced vital capacity. So after the maximal expiration, how much you can, after the maximal inspiration, how much you can maximally expire. That's what we are looking at. So 5 liters almost, from 2 to 7, right? This is 5 liters. And most of this, almost 4 liters, you can get out in the very first second, right? This we call FEV1, first second. You get 4 liters out. So 4 by 5, your ratio is 80%, right? This is normal. Now, if you look at obstructive disease, your FVC number is almost 3 liters. So low, as opposed to normal, which was 5 liters here, right? And now this patient, since they have obstruction issue, it's very difficult for them to get the air out in the very first second, right? So they are hardly getting 2 liters out in the very first second. So if you divide 2 by 3 here, you can see how the ratio is decreased, right? Now, if we look at the restrictive disease, as earlier explained, that these patients, they'll have thick fibrotic lungs, which are, scar tissue. It's full of elastins, less compliant. So what's going to happen the moment they try to fill those air in the lungs, it's going to deflate back or snap back. So you will get pretty much out of the 3 liters, the FVC that they may have, which is quite similar to what this obstruction disease has, they will get pretty much all volume out in the very first second, and that increases their FeV1 FVC ratio. So almost 2.8 is out. Out of the 3 liters, 2.8 is out in the very first second. And you can imagine that's going to be 90% out in very first second. So that's how you see or you compare the FVC numbers on spirometry, and you can determine what kind of issue it is. I have given you COPD, mild, moderate, and severe numbers also, so just keep an eye on that. And asthma won't be like very severe numbers as I have given here. They'll be like near about 60% or somewhere there, you will see. But depending upon how chronic asthma is, the numbers may go down as well if it's very chronic. Okay. Now, this chart is a very good interpretation of things. So if it's an obstructive disease, look at the residual volume that these patients are trying to retain inside the lungs, and their ERV have changed as well. So ERV and RV would be changed because they're looking for now new FRC in the compliant lungs, right? So the lungs are more compliant. They've lost the elastin fibers, their alveoli have merged, so they are inflating nicely and not able to get that air out. So they are reaching out to a new FRC number, and that is comprising of their ERV and RV, right? So this is hugely changed now in obstruction. If you compare this to the restricted disease, you can very well appreciate how this ERV and RV have decreased in a restrictive lung disease. And that would impact the total lung capacity in both. So you see, if the retaining numbers or the FRC is lowered, it will impact the whole TLC. As if you see here, these are much more in volume, and that would impact the TLC in obstructive disease. Is it making sense? Everyone getting the point? Yes? All right, so now the questions for you. What do you think in fibrosis will happen to total lung capacity? Decreased or increased? These exercises will be important for the exam, so you got to finish them and go over the charts. Yeah, total lung capacity is decreased. FRC is decreased as well, right? Residual volume is decreased. The lung capacity diffusion is also decreased, right? The ratio is FEV1 FVC ratio is rising. Very nice. Not changed or rising. Yes, Diego.
We will get this document later, right?
Yeah, it will be posted
Thank you.
tonight. Yes. It's already there in week 1, week 2. I have put these exercises already for you guys. I told you, and I filled up everything there. So please make sure that you finish all those big questions as well. So what's going to happen in emphysema? I need one volunteer to answer me all the questions, please. Yes, Amir, go ahead.
Okay, so essentially it's going to be pretty much the exact opposite of what we saw in fibrosis. So because air has an easier time getting in but a tougher time getting out, what that's just going to mean is that your total lung capacity will increase, your functional residual capacity will increase, and your residual volume will also increase. DLCO would also decrease because there's less surface area due to destruction of the alveolar walls, and your FV1 and FVC ratio would decrease because the amount of air that you're maintaining is going to be significantly more than comparison. I'm sorry, the amount of air that you can give out is going to be drastically reduced in comparison to fibrosis.
Because you have obstruction there.
Correct.
Right?
Yes.
Yeah.
Yeah.
Perfect. All right. I think you're doing well with these, but just take these exercises and try doing them. Assume them in the form of a clinical STEM and just go by that, right? All right. Dr. Shah, I'll try to finish by 4:30 or so, and then you can review ANS after. Dr. Shah? All right, who's going to explain? Yes, I see the answers. Do we have a volunteer to explain this? Yes, Sadaf.
So the answer would be B, because we get lower airflow, lower gas exchange.
This has nothing to do with the gas exchange at
I mean,
this
like the
point.
airflow, yeah.
These are the spirometry.
Yeah.
Yeah, these are the spirometry results, right? So, A is normal, Alana.
Dr. Carr, would it be C because it sounds like maybe it's asthma or obstructive and they're having trouble getting out the expiration?
It's not C, Mark. It would be B. The answer was correct. It's just the way they were explaining. I wanted like a little bit more like to the point answer. This is fibrosis, Skylar. Someone would like to explain? Yes, Christian?
I was going to say it sounds like an obstructive issue rather than like a restrictive issue, so that's why it's B.
It's not obstructive issue. It's a coal miner. We are talking about coal miner. So, these are the coal particles that he's been exposed for certain time. And other thing is that there is a dry cough, right? And other thing that you can look in the stem is just for past 4 months. So something that has relatively happened recently. It's not COPD. And if you look at the obstructive curve, these are the curves I discussed in class as well earlier. So you would see a kink here. This thing shows you that they will have hard time expiring the air out. So whenever you see this kink happening here, that means it tells you that this is an obstructive disease where they are having problem expiring the air out. Whereas fibrosis, they don't have problem. It's just the loop could be smaller, the volume could be smaller than normal. So here you have normal, right? And the whole flow chart would show you smaller loops in case of fibrosis, just because they don't have that much FVC, right? But if you look at the stem, this is a coal miner, so exposure to asbestos, silica, coal mining, or other organic chemicals that can set in the fibrosis in the lungs. That's what it seems like. And they are having dry cough. It's not productive cough. And other thing is that it's not a chronic thing that we are looking here. The obstructive curve that you are looking here seems very small FVC here, which is basically telling you that it's probably pretty chronic. Okay? Yes, Amir.
Sorry, Dr. Cora. I know this is I know Dr. Shah's probably busy now, but I know this is not your domain. But I know we've been talking a lot about specific drugs like recently, and I know would we focus more on class, or like the only specifics I know we really covered in depth would be albuterol and atropine. But like in ANS
Whatever he has
pharmacology,
mentioned in the drug list, that should be good.
Okay.
Okay. So we want to go more mechanism based. So you will see. So chronic, yes, Mark, it has to be a few years to consider it chronic. Yeah, and other thing is the age for obstruction. Like for COPD, you have to have, an older age that you look for in a stem, basically. Yeah. Okay. All right. I'm just going to get to the next question because I don't want to spend too much time. You need to know the curves, so just make sure that you go over these curves that we discussed earlier, the flow volume loops, the coving that you see on the obstruction. That is very important, which is basically telling you that the expiration is not normal in these patients. Whereas in restrictive, the whole loop is much smaller than normal. The normal is this dotted line that you see there. Okay. Only reason bringing you this curve is showing you the coving in the expiratory flow, which is not smooth. Yes, Jasmine.
I just have a quick question. What is PEFR? Does that mean?
This is the peak expiratory flow rate.
Okay.
So that's the flow rate that you are looking, right? And
Okay, thank you.
yeah, so you try to expire the air out, and that should the peak, if you look in the normal, it's right here, right? But they don't have that much peak compared to the normal, right?
Thank you.
You don't have to know like this much on the loop. Just how much I have explained is good enough. The A gradient question, we discussed this in class. If you are good with the alveolar gas equation and you know how to calculate, I probably won't go over this as much because I feel that once you know the alveolar gas equation, you can very well plug in those numbers and, check the gradient, difference between the alveolar and arterial oxygen. Basically, that's what you're looking for. All right, so I think this will be the last question for me, and then I'm just gonna ask Dr. Shah to continue from here. All right, so let's try it one more time. We did it in class, but I just want to go over it one more time.
May I volunteer, ma'am?
Yeah, sure, Prambit, go ahead.
It would be D.
It will be the D. That's not gonna cause hypoxemia, right? And how do you think other scenarios will be causing it?
Well, it would be D because synthetic oxygen carrier, such as erythropoietin, they stimulate the production of red blood cells, which would which would cause the oxygen in blood oxygen to increase. Whereas the right to left shunt, it's as we discussed in class, it's essentially bypassing ventilated alveoli and diluting mixing with the oxygenated blood and therefore diluting it and causing the O2 to go down in the blood. And then high altitude and hyperventilation, they hyperventilation retains CO2.
Yes. Very nice. So very well explained. Thank you. Which are the conditions you think that will bring the A gradient increase? Amir?
You got a COPD, asthma, emphysema, like any condition that's restricted that prevents oxygen from effectively reaching the blood will have an overall increase in the gradient, especially the right-left shunt, because now, like you explained before earlier, what's going to happen is that blood isn't going to reach well-ventilated areas because that blood is being moved to outside the normal pathway.
Yeah, very nice. So everyone understands right to left shunt, or there is any question? I think I had few DO students who had this question. Do we have them on the call here? Does anyone want to explain right to left shunt to us? So we have it recorded. Yes, Andrew.
Oh, sure thing. Thank you. So basically for the right to left shunt, what's happening is that basically for feeder arteries and, coronary stuff, we're basically dumping deoxygenated blood from the right ventricle into the left ventricle. So basically what's happening is that's watering down our oxygenated blood that's going into the left ventricle. So it's watering down the PO2 content, the arterial content, which should be 100, but then it goes down slightly.
Yeah, so basically, thank you, Andrew. Thank you for answering. And all of them as students who've been answering, I'm sorry if I didn't say thank you enough. Good, productive session, actually. And I liked the way you have really interacted. I think you are getting the point. So let me explain it one more time. So here you have the venous blood coming, right? Let's assume that here is your right ventricle sitting, which is sending blood to the lungs, right? And lungs are bringing alveolar O2, which is 100, and that's where the exchange is happening. And now arterial blood has PO2, that is 100, right? And this is sent to the left ventricle. So let's assume the left ventricle is sitting here, right? Now the right to left shunt means that the deoxygenated blood, because of the septal defect, there is a small septum in the right ventricle to left ventricle, which is sending this deoxygenated blood directly to the left ventricle, even though it's receiving the blood from the lungs, which is fresh, but it's also getting mixed up with this deoxygenated blood, which is coming from the right ventricle. So this mix up is basically changing the number that is 100 here, this will be diluted down to 80 or something, right? So that's basically bringing you a gradient increase in case of right to left shunt. Is everyone clear about this? Or do we have any question on this? Are we good on this? Okay.
So the questions about this will be mostly like theoretical.
Yes. Yeah.
Okay. Perfect. Thank you.
Yeah. Thank you.
I do have a question, Dr. Carr.
Yes.
So going over some questions yesterday, we found one that was asking us whether to find out, to say which circulation had a higher pressure, whether it's pulmonary or, like systemic circulation in regards to pressure. I know that we were using the book before, and the cardiopulmonary was before. Is that a question that I need to have cardiopulmonary background
Just
so I can answer?
keep in mind that the pulmonary vasculature will always have a better compliance than the systemic. So the reason being, when the right ventricle is sending blood to the lungs, if you don't have that much compliant circulation in lungs, it's going to be very tough to do the gas exchange there, right? So it's always much compliant than the systemic. So keep that in mind. And this much only, whatever the book has, that is good enough for you to know. It doesn't have to be like something that you should have learned before from cardio. This is going to come back to you again when you are learning cardio from next week. But for now, up to this is good enough. Whatever book says, just read that much.
Got it. No, it's just that we got that question from the book, but because chapter pulmonary is after chapter cardio, so I was wondering about that.
Yeah, no, as I said, just that paragraph is good enough. I remember there is one paragraph in Costanzo that explains it, but always keep in mind, since right ventricle is sending blood to the capillaries, and higher compliance does help in the gas exchange there. So that should be good enough. Okay. All right, guys, I think I'm gonna stop it here. I'm
Thank
not
you.
sure if Dr. Shah is gonna continue, but we will continue tomorrow morning, as I said. So I will meet with you tomorrow, and we will go over week 3 stuff, since we have another hour sitting there, and we may have some time left over in any case you have more questions that are left there. Okay. All right. Thank you all, and good luck. Just let me know. As I said, I'll be available Sunday night too for any last minute questions if anyone has. But in between, just send me your questions with your phone number, then I'll give you a call.
Dr. Kerr, I have a quick question. What time is it for tomorrow?
Yeah, I'm gonna send it through Ellen. Okay.
Okay, yeah, because
Yeah.
everybody keeps changing times, and I know our anatomy tomorrow is mandatory because it's going to be a lecture type, Dr. Morgan said.
Okay, I'll let you know. Okay.
Thank you.
All right, thank you. Jasmine, you have a question?
Yeah, I don't know if Dr. Shaw is still on this.
He's here. He's here. I'm not sure if he's answering now. Dr. Shah? Yeah.
I think because one of the previous questions we had, we talked about atropine or something like that. I'm looking at, as an MS student, I'm looking at our drug list, and we have like epinephrine, norepinephrine, acetylcholine, atropine, neostigmine, albuterol, ACE inhibitors, beta blocker, calcium channel blocker, digoxin, alpha 1 blocker, nitric oxide, and phenylephrine. I didn't see theotropium or
Theotropium? Yeah. I mean, as I said, we will go mechanism based, most likely. So, anything that is there, if there is something missing, I'll check with him one more time. If, he needs to add it, he'll add it. Okay.
Okay.
But in the meantime, if you can email him, that would be great.
Okay, thank you.
Yeah. Mark, you have a question?
Yes, thank you, Dr. Carr. Are you able just to clarify the difference between hypoxemia and hypoxia? Hypoxemia is just the arterial PO2 is decreased, and hypoxia is just the tissue O2 is decreased. Is that correct?
Yeah, absolutely. Absolutely. So if you have blood partial pressure of oxygen going down, that would be your hypoxemia. And if that gets translated further down into the tissues, that would be hypoxia. But sometimes, how we were looking at cyanide poisoning.